Good afternoon, dear professors, colleagues. It is my pleasure today to have our eminent cardiology with an interesting topics in wave 2 heart failure. We have Dr. Mahmoud Hassanin, professors of cardiology at Alexandria University, then Dr. Sahar Azab, professor of cardiology at Alexandria University, and finally Dr. Hani Raudi, professor of cardiology, National Heart Institute. We start with Dr. Mahmoud Hassanin with an important topic with heart failure in Egypt and its burden. Please, Dr. Mahmoud, start with us. The waiting for you.
مساء الخير, السلام عليكم. I'm happy to meet with you, this respectful audience. I would like to thank Novartis for sponsoring this symposium, and I would like to thank the technical assistance by ICO. Our subject today is about heart failure in Egypt. We want to define the failure. So this is a part of the European Society of Cardiology Heart Failure Long-Term Registry, which is a prospective multi-center observational study of patients presenting to cardiology centers in European and Mediterranean member countries of the European Society of Cardiology. Egypt is a full member of the European Society of Cardiology. We participated in this registry as a member, and because we lacked data about Egyptian patients with heart failure. The study started from April 2011 to February 2014, and a total of 2,145 patients with heart failure were recruited from 20 centers all over Egypt. The aim of the study was to describe the demographic and the clinical characteristics and management of patients hospitalized with acute heart failure and patients with chronic heart failure seen as outpatients in cardiology centers in Egypt. The second aim of the study was to compare heart failure patients from the Egyptian cohort with heart failure patients from other European countries participating in the registry. يبقى الغرض كان two purpose. أولا نعرف define our Egyptian patient, and to compare this patient, heart failure patient, with heart failure patients from Europe. So our Egyptian cohort, this was a publication, international publication in the ESC Heart Failure Journal, published in the year 2015. And you see the names of the principal investigators of this registry. Patients were recruited from 20 centers all over Egypt, from Alexandria, Bahira, many governorates in the Delta, زي طنطا, شبين الكوم, الزقازيق, بنها, شبين الكوم, and from Upper Egypt, كان من بني سويف ومن أسيوط, كمان from Greater Cairo, and from the Suez Canal region, from Port Said. 2,145 patients were recruited, 2,145 عيان. This is a good number to analyze. 2/3 of those patients were hospitalized patients with heart failure, and 1/3 were chronic heart failure seen in the outpatient clinics. What we are showing today is patients hospitalized with heart failure. The mean age of our patient was 60 years. Body mass index was 30.228, and we know that the cutoff value for obesity is 30 kilogram per square meter or above that. Mean ejection fraction was 38%, which means that most of the patients presented with heart failure with reduced ejection fraction, and hemoglobin concentration was 12.05 grams per deciliter. Again, patients who were above the age of 70 years comprise only 23% of our patients. So most 70%, or more than, I would say, 68% of our patients were below the age of 70. 30% of our patients were females. So men were affected with heart failure as twice as common as females. Body mass index, mean body mass index was 46.9, which means that almost half of our patients were obese. And an ejection fraction above 45% at that time, the cutoff value for preserved ejection fraction was more than 45%. So only 22% of our patients had heart failure with preserved ejection fraction, which means that most of the patients in Egypt present with heart failure with reduced ejection fraction. Concerning cardiovascular risk factors in our patients, hospitalized patients with heart failure, 45% of patients with heart failure had diabetes mellitus. This is an important piece of information. 43.5% had hypertension or history of hypertension, and 60% of our patients were smokers. The main etiology of heart failure in our patients with ischemic heart disease in 68% of the total population, which means that more than 2/3 of patients had underlying etiology of ischemic heart disease. The second common etiology was dilated cardiomyopathy, comprising 15.5%. Now we come to the second part, which is comparison of hospitalized heart failure in Egypt versus hospitalized heart failure patients in Europe. Remember that both groups were recruited at the same time. So patients above the age of 70 years, Egypt is in orange color and European countries in the blue color. So patients above the age of 70 years, there were only 23% of our Egyptian patients above the age of 70 years versus 60% of European patients, which means that our Egyptian patients present at a much younger age, at least 10 years younger than their European counterparts. Obesity was present in almost 47% of our patients versus 28% of European patients, which means that obesity is a salient feature in our heart failure patients. Females comprise 30% of our patients versus 39% of European patients. Preserved ejection fraction, only 22% of our Egyptian cohort presented with heart failure with preserved ejection fraction versus almost 36% of European patients. And the prevalence of atrial fibrillation was 24% in our patients, Egyptian patients, versus 48% in European patients. It's almost half the prevalence. Concerning cardiovascular risk factors, diabetes was present in 45% of our patients versus 35% of European patients, which means that diabetes is more prevalent in Egyptian patients with heart failure. On the converse, hypertension is more prevalent in European patients, was almost 70% versus 43% of our Egyptian patients. Smoking is much more prevalent in Egyptian patients, 61% versus 47% in European patients. Concerning other comorbidities such as renal dysfunction, prior stroke, peripheral arterial disease were more common in European patients, but remind you that hepatic dysfunction was more common in our Egyptian patients. We know that our Egyptian patients suffer from liver disease due to endemic hepatitis C virus and other causes of liver disease. Another publication from our Egyptian registry was comparing men and women with heart failure. Do they behave the same? Well, the mean age at presentation was almost equal, men and women, no difference in age at presentation. But women presented with a higher systolic blood pressure and a higher resting heart rate. Again, obesity was much more common in women versus men. 66% of women were obese versus 43% of men hospitalized with heart failure. The primary etiology of heart failure was not different between men and women, whether ischemic, dilated, valvular, or hypertensive. No difference in primary etiology. However, again, atrial fibrillation was more common in women with heart failure. Almost 35% of women presenting with heart failure or hospitalized with heart failure had atrial fibrillation versus 22% of men. Cardiovascular risk factors in our patients, smoking was much more common in men. It was almost universal. Almost 83% of men with heart failure were smokers versus 9% of women. However, diabetes and hypertension were significantly more frequent in women than in men. Then we come to the categories of heart failure. Most patients, whether men or women, presented with heart failure with reduced ejection fraction. But look to heart failure with preserved ejection fraction. It was much more common in women. Almost 30% of women had heart failure with preserved ejection fraction versus 11% of men. If we come to precipitating factors for heart failure, we find that myocardial ischemia was an important precipitating factor in men versus women. However, atrial fibrillation, uncontrolled hypertension, and anemia were more frequent precipitating factors in women with heart failure than in men. If we look to the comorbidities in both genders, anemia was more common in women, diabetes was more common in women, hypertension was more common in women, but renal dysfunction, hepatic dysfunction, and the chronic obstructive pulmonary disease were more frequent in men. Concerning mortality, in-hospital mortality and one-year mortality were not different. There was no significant difference between women and men concerning in-hospital and one-year mortality. So the results, or we come to the conclusion of our study, this was the heart failure in Egypt. والحقيقة أنا أحب أقول إن يمكن إن ده كان team work. 20 centers all over Egypt contributed to this registry, and why this was a success story. When we work together as a team, we can achieve marvelous results. Heart failure patients in Egypt have distinct demographic and clinical features different from other European countries. لأن احنا شفنا في اختلافات كبيرة ما بين our Egyptian patients and European patients, and this should be put in consideration when planning preventive measures and treatment measures. Men and women afflicted with heart failure differ significantly in baseline clinical characteristics, but not in adverse outcomes. Mortality was the same. These findings highlight the value of national registries in planning primary prevention programs. Heart failure management programs should be established all over the country to improve patient management and outcomes. Thank you for your attention. عبد الرحمن اتفضل.
شكرا يا فندم، شكرا على المحاضره الجميله والمعلومات القيمه، وقد ايه عرفنا ان في ايفورت في الريجستري مبذول مشكور جدا من الناس اللي بذلت المجهود الكبير ده، وقد ايه عرفنا ان في فرق بين اليوروبيان والايجيبشن ريجستري، ان في اريا كبيره من الامبروفمنت ممكن نحسنها، especially ان عندنا الهارت فيلير بريزنتد ايرلي جدا في يونجر ايج عن بره، وقد ايه الاي اف اكتر بره مع الايجنج، وفي الديابيتس اكتر ما عندنا، وقد ايه ان احنا عندنا اريا من البريفنتيف ميجرمنتس اللي كان ديكريز النمبرز اوف هارت فيلير والبرزنتيشن، وقد ايه الهوسبيتالز مليانه بهارت فيلير، وقد ايه العيان دول ممكن نحسن جزء كبير منها. شكرا يا فندم على المعلومات الكبيره والاريا اللي احنا نقدر نمشي فيها في البريفنتيف كارديولوجي ان شاء الله نقدر نحسن الدنيا. وشكرا.
انا ليا كومنت عايز اقول، زي ما شفنا في one of the slides ان 2/3 of patients had an underlying ischemic etiology, ischemic heart disease, and we know the risk factors for coronary heart disease سواء diabetes, hypertension, smoking, dyslipidemia, lifestyle. فأنا بقول إن heart failure is mainly a preventable disease. We should aim to work hard to prevent heart failure. It is still a preventable disease.
فعلا يا فندم، مختلفة عن بره، في جزء منه ايجنج، اما هنا في جزء كبير منه بريفنتيف.
Yes, sure.
شكرا يا فندم، شكرا. ممكن 30 ثانية بريك وندخل على المحاضرة الثانية ان شاء الله. المحاضرة الثانية إن شاء الله هتكون مع البروفيسور دكتور سحر عزب، Professor of Cardiology at Alexandria University, and the role of echo as fundamental in heart failure diagnosis. اتفضل يا فندم، وإن شاء الله نستفيد كلنا من المحاضرة إن شاء الله.
Good evening everybody and good evening my colleagues. Bismillah ar-Rahman ar-Rahim. My lecture today is about role of echocardiography as fundamental in heart failure diagnosis. As we know that the echo is a cornerstone points in the diagnosis of all cardiac lesions in the tissue. Heart failure is defined as a complex clinical syndrome that can result from any structural or functional cardiac disorder that impair the ability of ventricles to fill with or eject blood, which includes either diastolic as well as systolic heart failure. The American College of Cardiology, American Heart Association guidelines, as well as the European Society of Cardiology, state that echocardiography is the single most useful test in the diagnosis of heart failure, since structural abnormality, systolic dysfunction, diastolic dysfunction, or a combination of these abnormalities needs to be documented in patients who present with resting and exertional symptoms of heart failure to establish a definitive diagnosis of heart failure. As we use some laboratory diagnosis like the brain natriuretic peptide, usually some persons may depend on it in the diagnosis because it provides information regarding left ventricle, left atrial wall stress and pressure, distinguish heart failure from other causes of short of breathing, tracks efficacy of therapy, assessment prognosis, compensation and decompensation currently underway. But as we know that this mode of diagnosis usually may be affected because it usually depends on the pressure or the stress wall on the left ventricular wall and left atrial wall. Usually it may be affected by some drug like the ACE inhibitor, the ARBs. Also it may be affected by age. It may be elevated. It may be elevated in obese person due to the presence of epicardial fat. This epicardial fat acts as a pressure on the left ventricle, which may increase the intraventricular pressure and may give us a false result and false positive result of the natriuretic peptide. Diagnosing, usually we have a challenging problem in the diagnosis of a group of patients with a group of heart failure patient with preserved ejection fraction, which is called HFpEF. As regard patients with HFrEF is easily diagnosed by echo. The diagnosis of HFrEF is the definition of heart failure symptoms with ejection fraction less than 40%, usually quantified by Simpson biplane method. A new group of patients has been introduced in the latest 2016. This patient group has been termed heart failure with mid-range ejection fraction. And those comprises with heart failure symptoms with ejection fraction range between 40 to 49%, elevated level of natriuretic peptide, and either associated with structural heart disease like left ventricular hypertrophy or left atrial enlargement, may be associated with diastolic dysfunction. According to the European Society of Cardiology, introducing this patient group as an entity independent of HFpEF and HFrEF was done to stimulate research into the underlying characteristics, pathophysiology, and treatment of this group of patients. Patients with mid-range ejection fraction are estimated to comprise about 10 to 20% of all heart failure patients and currently occupy a gray zone in the heart failure literature. As we know that all modalities of echo are useful in the assessment of the heart failure. Historically, we start this measurement by mode that remain helpful for accurate assessment of wall and chamber dimension. But as we know that we can't use M mode for measurement of ejection fraction in case of the presence of wall motion abnormality, either akinesia or dyskinesia or hypokinesia. So we shift to 2D echocardiography, which added the ability to assess left ventricular volume and valvular disease. In addition, after that, we progressed to use the 3D echo, which has enhanced the accuracy and reliability with which chamber volume and function are measured, as well as the mechanistic evaluation of regurgitation. As we know that the important parameter for diagnosis and categorization of patients with heart failure is the ejection fraction. Ejection fraction has central role in the management of heart failure, identifying patients who are likely to respond to therapy for heart failure with reduced ejection fraction, as well as patients who will benefit from device therapy, either implanted defibrillator or cardiac resynchronization therapy. As we know that even by mere inspection of the heart, we can detect if this heart has a normal ejection fraction or reduced ejection fraction. As we know here that this heart, الفيديو بس تقيل شوية, that this heart has a normal function, and we see that there is no wall motion abnormality with a normal dimension, and we can judge that this patient has a normal ejection fraction. But we don't satisfy but the term only normal ejection fraction, but we need to measure this ejection fraction. So as we know that to measure ejection fraction by 2D, we must use modified Simpson rule. And this modified Simpson method, we can planimetry the endocardium from inside during end systole and end diastole, and by the software of the apparatus, it will minimize it will calculate the ejection fraction, and we can categorize the patient either HFpEF or HFrEF or mid-range. Modified Simpson rule usually depend on the endocardial border. If we can see the accurate endocardial border, usually we will have a false results. Also, this ejection fraction usually load dependent. If there is a mitral regurg, this will give us a false positive results about the ejection fraction and give us a certain increase in the value of the ejection fraction. As if we see this picture, we find that in the same patient with change in the planimetry by modified Simpson rule, this is the end diastolic and the end systolic. This is the end diastolic and systolic. Only we change our hand in drawing the endocardial wall. We found there is marked difference in the ejection fraction from the 39% to 35%. So drawing the borders of the endocardium is a very important mode to detect the ejection fraction. If we see this patient, we find that this patient had a huge apical thrombus, as we see here. If we draw the endocardial border and take in consideration take into consideration this large apical scar, so the end diastolic volume here will appear so large and give us a false result about the ejection fraction. Here we must take the endocardial border below these big or huge apical thrombus to avoid having a false results about the ejection fraction. By echo distinction of cardiomyopathy, we have different type of cardiomyopathy, either dilated cardiomyopathy, hypertrophic or restrictive cardiomyopathy. We found that in the left ventricular volume markedly increased in the dilated cardiomyopathy, with more or less decrease in the hypertrophic cardiomyopathy with no change in the restrictive cardiomyopathy. As regards the wall thickness, we found that in the dilated cardiomyopathy more or less normal or sometimes decrease, markedly increased, especially the interventricular septum in case of HOCM, with increased thickness, but the normal myocardium is changed in restrictive cardiomyopathy. Contractility is markedly decreased in dilated cardiomyopathy. The contractility no change, and it decrease or little bit decrease in restrictive cardiomyopathy. And all these data can be taken from 2D echocardiography. If we see here, we find that this patient has a dilated cardiomyopathy. We found that there is marked increase in the left ventricular volume with global hypokinesia of all the wall of the left ventricle, and this can differentiate this dilated cardiomyopathy from ischemic cardiomyopathy. This is because in case of ischemic cardiomyopathy, there is regional wall motion abnormality that only one segment have hypokinesia or dyskinesia, and the rest segments move normally. Also here we can see behind the right atrium a minimal amount of pericardial effusion due to this heart failure. All this data is taken from this 2D about the valvular, if there is valvular lesion, if there is wall motion abnormality, the presence of pericardial effusion, the thickness of the myocardium. This is a short axis view of a patient of dilated cardiomyopathy, which showing increased dimensions of the left ventricle with increased left ventricular volumes and global hypokinesia of all the wall, anterior, septal, inferior, and lateral wall. Also, mitral regurg usually present in case of heart failure. Functional mitral regurg is characterized by tethering of the leaflet and the jet that is usually central or posteriorly directed in the absence of anterior leaflet prolapse. Ischemic mitral regurg may also be associated with commissural jet related to loss of support from one or other papillary muscle. Here we can see patients with dilated cardiomyopathy and severe mitral regurg. Here we can see that there is normal thickness of the mitral leaflet, and we can call that this is a functional mitral regurg. We can see here the mitral leaflet without any stenotic lesion to exclude that this mitral regurg is due to rheumatic origin, and we see that the left ventricle has a dilated dimension. Also, the patient has sclerotic aortic valve. We can see in the left parasternal view that the mitral regurg is severe and eccentric. As we see, all this is mitral regurg due to dilated cardiomyopathy. Left atrial volumes. The left atrial volume is a very well predictor or very indicator for heart failure, including the atrial fibrillation. In a patient with suspected heart failure, the absence of left atrial enlargement, which is about 35 milliliter per meter square, indicate either that the process is acute or that sustained elevation of filling pressure has not occurred. Left atrial volume is a valuable prognostic marker, is measured using a biplane approach in the apical view. Also, we can measure it by 3D echo. Here is the apical four-chamber view, and this is the planimetry to measure the left atrium. This patient has a left ventricle volume index 73, which is more than normal. The normal is 35, more than 35, and left ventricular mass index is 130 gram per meter square. This left atrial dimension is associated, dilatation is associated with left ventricular hypertrophy. Doppler assessment of hemodynamics has become an indispensable adjunct to heart failure evaluation, including assessment of pulmonary artery and right atrial pressure, left ventricular filling, and regurgitant jet. If we start to speak or to examine the diastolic function and left ventricular filling pressure, we found that this is the normal diastolic flow. Here we put it on the mitral inflow pulsed Doppler, and we find that this is the peak E, the peak A. E/A ratio, this is normal. We find that the E/A ratio varies between 0.7 to 1.5, and the deceleration time is varies between 140 to 220 milliseconds. If this normal change to impaired relaxation stage 1, we found that there is no change in the compliance of the left ventricle, but the relaxation starts to be affected. Come here in the red zone. And we found that the peak E start to be less than the peak A, and the E/A ratio start to be 0.7, less than 1, and the deceleration time is still more than 220. At the same time, this is the pulmonary flow pulsed Doppler. We found that the systolic pressure here is more than the diastolic pressure. And this is the normal condition of the pulmonary flow. We found that when we move to the impaired relaxation, the systolic flow is more than diastolic, but it is less than normal. The pseudo-normalization here, that the diastolic flow return to normal by the pattern, but it is usually there is reverse of the pulmonary flow where the diastolic pressure increase more than the systolic pressure and the deceleration time is more than 30 milliseconds. This we call it pseudo-normal because it is appear like normal, but usually by Valsalva maneuver, we found that it regained again to the diastolic abnormality and the A wave become more than the A wave. When we progress to more diastolic dysfunction, reversible to the stage 3, we found that there is more pseudo-normalization, and this form will not be changed by the Valsalva maneuver, with marked decrease in the systolic pressure in the pulmonary flow. The stage 4 is a fixed restrictive form where there is affection in both compliance and relaxation, and the left atrial pressure become more high, more than 15 millimeter mercury. But here we found that the E/A ratio is more than 1, but the deceleration time is less than 150 milliseconds. So, if we talk about the parameters we use to detect left ventricular diastolic dysfunction, we found that this is usually taken into consideration if in the tissue Doppler, the E' at the septal level, at the septum end of the mitral annulus is less than 7 centimeters per second. The E' at the lateral annulus of the mitral second is less than 10 centimeters per second. Average E/E' more than 14. The left atrial volume index more than 34 milli. The peak tricuspid regurg is more than 2.8. In this algorithm, we take into consideration how we can diagnose diastolic dysfunction. This is patient with HFpEF, reserved left ventricular ejection fraction. We take into consideration all these parameters: E/E' ratio, septal tissue Doppler, septal E', lateral E', tricuspid regurg velocity, left atrial volume. If we have less than 2 parameters, usually we have normal diastolic function. More about 2 parameters only, this is indeterminate. More than 2 parameters, 3 or 4 parameters, this is an obvious diastolic dysfunction. So the recommendation for cardiac imaging in patients with suspected or established heart failure, that in patients with HFpEF or HFrEF, it is class 1C. Transthoracic is recommended to assess left ventricular ejection fraction in order to identify the cause and to identify the patient who will be subjected to ICD or CRT, class 1C. Also in those patients, to assess the myocardial structure and function is subject to be exposed to treatment which potentially can damage myocardium, class 1C. Patient with suspected acute heart failure, echocardiography is recommended immediately in hemodynamically unstable acute heart failure patient and within 48 hours when cardiac structure and function are either not known or may have changed since previous studies, class 1C. Also, in all patients with suspected cardiogenic shock, immediate ECG and echocardiography are recommended, class 1C. The recent development of myocardial strain has facilitated the assessment of long axis function, which is sensitive to preclinical phase of heart failure, which is called the strain pattern. As we know that the myocardium or the myocardial fiber are as arranged in the left ventricular wall longitudinally, circumferentially, and circularly, and this allow, due to its contraction, this allow the pumping of blood. This contraction is result due to the strain is a mean of measuring myocardial deformation. Speckle tracking of grayscale images has been the method of choice over a decade. Global longitudinal strain, which usually depend on it in the evaluation of left ventricular function. Strain rate is better recognized usually by the global longitudinal strain. This is speckle tracking by longitudinal fibers, the radial fiber and the circumferential fiber. It appears like this by a color, and by this graph we can detect if there is abnormal function or a normal function. Usually we depend on the longitudinal strain. The value is usually by the minus. This is because the fiber usually shortening, so it will be by the minus value. Usually we depend here on the global longitudinal strain, which this is the normal value, minus 20.5. And if we can see here this scale, we found that the red color is the normal color, the pink is the intermediate, and the blue color is the more worse color. And here 2D strain allow evaluation of global and regional myocardial deformation. The regional pattern of myocardial dysfunction may suggest the etiology of heart failure. Here this is a patient with coronary heart disease. Here is the area of ischemia appear with pink, and this is the normal myocardium. This and the global longitudinal strain is minus 12. But here the dilated cardiomyopathy, due to affection of all region of the myocardium, we found that the color is between pink and blue. And if we see here the color scale, we found that the pink and the blue color is the worst one, and the global longitudinal strain minus 4. We know that the normal is minus 20. If we come here and we found that, as we all first, that the ejection fraction, we can categorize the patient by ejection fraction. If we see this patient, we found that the three groups of patients here is 59, 61, 58, and the three have normal ejection fraction. But this patient is normal, this patient has apical hook'em, and this patient has amyloidosis. But we can differentiate the degree of dysfunction by ejection fraction at all. If we take into consideration speckle tracking, we found that this is a normal one, all the color is red one. This is the apical hook'em. The color here is normal. Only in the apex there is affection. In the amyloidosis, we found that the color is very bad, and the only spared part of normal myocardium is at the apex. So, if we take into consideration this parameter, we found that left ventricular ejection fraction subclinically normal, and it will be reduced in the HFrEF only. But if we take into consideration global longitudinal strain, we found that it is reduced in all the stage, in the subclinical, in HFpEF and HFrEF, and this is a very sensitive parameter to diagnose patient with heart failure. Lastly, the right ventricular function. As we know that right ventricular function is very difficult to be diagnosed due to the structural and the structure of the right ventricle and the difficulty in delineation of the border. But one of the most easiest methods to diagnose right ventricular function is the TAPSE, tricuspid annular plane systolic exertion, which is normal more than 24 millimeter. If it is less than 8.5, usually ejection fraction is less than 25, and if it is at general, if we take into consideration the TAPSE, if it is less than 14 millimeter, usually the patient have a poor prognosis. Also, the tricuspid regurg here can give us an idea about the pulmonary artery pressure and the right ventricular function. My conclusion is that echocardiography play a key role in patients with heart failure for diagnosis, prognostic stratification and treatment planning and monitoring. Assessing cardiac structure and function allow a comprehensive evaluation of the patient's status for better decision making. Newer methods like strain imaging based may further add to the echo data, providing incremental information to the conventional one. The different imaging modality should be used in a complementary way as needed to solve the clinical question. Thank you very much for your attention.
انت muted يا دكتور عبد الرحمن، انت muted.
Thank you, Dr. Sahar, for the elegant presentation. And we now know how the echo is important, not just for the diagnosis, but we can put a plan for the patient, either doing a medical treatment or start ICD or CRT with echo to put a further plan for the patient. Also, we know that the right ventricle, which is the neglected neighbor of the heart, how is it affect the prognosis of the cases, and how it is important to assess the RV in cases with heart failure. Thank you, Dr. Sahar, for this elegant presentation.
Thank you very much.
We have two questions from the audience. I know that the two question is not related to the echo, but they asked about the recent treatment of heart failure and heart failure treatment with mid-range ejection fraction.
Usually, these depend on the symptoms of the patient. Usually, all the patients with heart failure, the first symptoms of the patient, even patients with diastolic dysfunction with preserved ejection fraction, is the dyspnea. So all grades of dyspnea can be treated by decongestion, by diuresis. Also, we can add AC or ARBs, provided that the function, the kidney function, we put on ion kidney function. We can add small dose of beta blocker, as we know that the patient with heart failure with high dose of catecholamine usually have a higher heart rate, and so we can add a small dose of beta blocker. If all this can't improve the patient, as we know that we can add Entresto to the patient, which improve the myocardial function. And at the end of all this, if the ejection fraction in patients with HFrEF, when ejection fraction start to be reduced than 35% with paradoxical septal motion, with the increased duration of QRS complex, we can add CRT. So usually the treatment depends on the clinical presentation of the patient, on ejection fraction, but now we don't depend mainly on ejection fraction, but we usually depend mainly, like I tell that global longitudinal strain by speckle tracking, because the patient may have a normal ejection fraction, but with reduced global longitudinal strain, and this will give, we found that there is a very large entity of patients don't respond to medical treatment. This is because they have a normal ejection fraction, but there is affection in the contraction, in the myocardial contractility. So I suggest that or recommend that most patients or all patients subjected to speckle tracking to detect the global longitudinal strain, especially if this patient will plan to use resynchronization therapy to know the normal myocardium when we will insert the electrode for this patient.
Thank you, Dr. Sahar, for the presentation and answering the questions. Now we will start. ممكن 30 seconds for break and then rejoin again the webinar. Thank you. The next presentation was Professor Dr. Hani Radi, Professor of Cardiology, National Heart Institute, and very important presentation about the heart failure and the role of biomarker and how the biomarker can help us in the diagnosis and the prognostication of the cases. I know that it will be a fantastic presentation. Start and learn us, Dr. Hani.
Thank you very much, Dr. Rahman, for the kind introduction. مساء الخير جميعا. Thank you very much for the audience and for the sponsor Novartis, and also for the technical support from ICOM. I'm honored to speak after the two distinguished speakers, Professor Mahmoud Hassanein and Professor Sahar Azam. Professor Hassanein showed us the magnitude of the problem of heart failure in Egypt, and Professor Sahar showed us something extremely important for my presentation. She showed us how complicated and how important the echo is, because a lot of people think that echo is something easy. It's not that easy, and the number of echo machines in Egypt and the number of echo operators compared to the patients in heart failure who need to be diagnosed immediately in the emergency room has a huge shortage. And this is the role of the biomarkers, which is very underused in Egypt, and I will discuss the reasons as well. So I will start straight away. So we use either BNP or NT-proBNP, but I will say why we prefer the NT-proBNP, and it empowers us for better management of heart failure at every stage. I want to show you one thing before we start. This is my mobile phone, and this is my echo machine. Okay, they're next to each other here. You can see them. It's the same size. Okay. Here, my mobile phone and my echo machine. My echo's in my hand. Okay. So this is my echo machine with the probe, and here with the probe. I carry a point of care echo, and I'm an echocardiographer. I probably don't, and even then, I find the biomarkers very useful. If we don't have access to immediate echo, we have a real problem, and we don't have access to immediate echo. So what are the biomarkers? What is the BNP and the NT-proBNP? When you have an increased myocardial wall stress due to increased volume or increased pressure overloads, as Professor Sahar showed us very elegantly, this overload activates natriuretic peptides in the cardiac myocytes. It activates the gene. So the gene, which is there, which is not producing BNP, suddenly starts producing the precursor of the natriuretic peptide, which is the proBNP. It then breaks down, a cleavage happens to release the biologically active natriuretic peptide, the BNP, and the biologically inert terminal fragment, the N-terminal proBNP. The BNP is like a drug. It stimulates natriuresis, stimulates vasodilatation. It is trying to work like neprilysin and like sacubitril and like anti-failure measures, okay? It's trying to like an neprilysin inhibitor, where it tries to treat the patient. It tries to work as a diuretic. It's trying to cause diuresis, natriuresis, vasodilatation with afterload reduction. It inhibits renin-angiotensin-aldosterone release, and inhibits sympathetic nervous activity and reduces fibrosis. This is a miracle from the human body, which shows one of the naturally occurring mechanisms to combat failure, which obviously does not work all the time and does not work when you have overwhelming causes of heart failure. So if you're talking to a non-cardiologist, tell them that the NT-proBNP is a protein which is released by the heart when the heart wall is stretched. And when the NT-proBNP in the blood is low, you can actually exclude heart failure. And when the NT-proBNP level in the blood is high, it can show you that there is heart failure. And the higher it gets, the worse is the heart failure. So while monitoring your patients, the changes in this level of the NT-proBNP will give you information about progression or regression, which is improvement of the patient's condition. We do know that heart failure affects patients more as they get older. And it really restricts their freedom in their senior years. It makes them breathless. It makes their ankles swell. It makes them very fatigued, and it causes extremely limited mobility. And eventually, it causes death, and it increases their mortality almost like worse than many, many known cancers. Heart failure is actually a problem. It's a problematic condition because we have problems in diagnosing it. It's not that easy to diagnose. And we also have problems managing it inside the hospital. And we have problems in disease monitoring. Once the patient goes home, how to know if they're doing well or getting worse, and when will they need rehospitalization. Just imagine an older patient, 70 years old, smoked all their lives, COPD, obese, and short of breath. Okay, and you know that they have heart failure, and you know that their ejection fraction is low. So, when they come with dyspnea, you don't know if this is a new episode of heart failure. Is it an exacerbation of the COPD? It's a very, very complicated matter. Those of you on the ground treating patients know how difficult it can get sometimes. And despite a lot of spending on health and on the rehospitalization and the mortality remains very high. 1 every 4, that's 25% of patients who are discharged from hospital will come back and be readmitted in less than 1 month after discharge. 50% of those patients, 1 every 2, were actually be readmitted in less than 6 months. 50% of those patients, that's 1 in 2, will die in 5 years. The survival rates of heart failure, poorly treated heart failure, are worse than the major cancers like bowel, breast, and prostate cancer. Only lung cancer is worse than heart failure. So heart failure symptoms are actually non-specific. You have an elderly patient with lung disease, and many of them are short of breath. Some are short of breath without heart failure. Echocardiograms, as Professor Sahar showed us now, are resource intensive. To do a proper echo, to be able to diagnose this patient at 3 o'clock in the morning when all the echocardiographers are asleep is difficult. It's nice to have a test, and I'll show you how you can use the test. You need early and accurate heart failure diagnosis to improve outcomes and to save resources. Once your patient is admitted, you need to plan, when am I going to discharge this patient? Is my patient better? I have used intravenous furosemide and the patient looks better. How do I know that when I send this patient home, he's not going to come back again after 12 hours or in a few days? And in disease monitoring, you need to know an objective marker when this patient, you're in Alexandria and your patient is in Asyut. How would you know how well your patient is doing? Maybe your patient can have a test, maybe your patient can have an echo. We'll discuss this. The guidelines recommend the use of natriuretic peptides as the diagnosis of heart failure. Upon presentation of a patient in heart failure, a natriuretic peptide level is recommended in all patients with acute dyspnea and in suspected acute heart failure to differentiate the acute heart failure from non-cardiac cause of acute dyspnea. And that's a class 1 level of evidence A. And the cutoff point for acute heart failure in NT-proBNP is 300 picograms per milliliter. So if your patient comes with acute dyspnea and you do it, I just had a patient done today in the morning. Her family called me and they said she had acute dyspnea and we're going to hospital. As soon as they arrived, they tested her NT-proBNP and it was 54. This is a non-cardiac acute dyspnea. This patient will either have bronchial asthma, will have pneumothorax, will have severe pleural effusion, but it's non-cardiac. So now she's being seen by a chest physician and she's undergoing chest CT. The plasma concentrations of the natriuretic peptides are actually an essential initial investigation, especially also in non-acute setting when echo is not immediately available. And in the non-acute setting, the cutoff point is 125 picogram per milliliter to rule out the heart failure in non-acute setting. So what does an essential initial investigation mean? It means you should ask yourself as an attendee of this meeting, how many times last year or last month did you order an NT-proBNP? And if you have not ordered it, you should know that you're actually breaking a very important guideline with the level of evidence class 1, level of evidence A. And we're going to discuss why you may not be doing that. This is not just Europe. The Canadian Cardiovascular Society, the ACC, the American Heart Association, the NICE guidelines in Britain, and the Scottish guidelines all recommend using natriuretic peptides. This is the gatekeeper to reduce resort wastage in echocardiograms. And not only that, you may have a well-known dilated cardiomyopathy patient who's been extremely well controlled and has a normal natriuretic peptide who comes to you with acute dyspnea. And the echo might not be helpful because there might not be new echo findings in this patient with an ejection fraction of 30. And in this case, the natriuretic peptide will be really helpful because if you do it and it's less than 300, this patient with known heart failure is unlikely to have an acute exacerbation, look for other symptoms. And the same for non-acute heart failure. So this is how you use it. It's a gatekeeper to reduce resource wastage in echocardiogram. You can have a point of care machine in every single intensive care, while you can only probably in Egypt have echocardiography in less than 10% of intensive care's available echocardiography at the time at 3 o'clock in the morning. In the emergency department, NT-proBNP will cause 40-minute reduction in emergency time versus usual care. It will cause 35% fewer patients rehospitalized in 2 months versus usual care, and a definite reduction in costs in both emergency room visits, hospitalizations, outpatient service, and this was published in Circulation. In the non-acute settings, we actually use a cutoff point of 125, and the negative predictive value to send the patient home is 97%. So this patient, you tell them, no, your heart is not causing you shortness of breath. It saves 40 to 45% of echocardiograms in those patients, and this is a huge degree of saving. It is one of the top 10 recommendations of the British Heart Foundations. It saves 50% of echoes in the UK. And in the UK, the NICE guidelines thinks that using pro-NT-BNP properly saves them £3.8 million every year. Early readmission is a huge challenge for people treating patients with heart failure. And we need better discharge planning. You don't want to discharge your patient too early, otherwise your patient is going to come back anytime between a few hours up to a few days. And many guidelines recommend natriuretic peptides testing inside the hospital for prognostic evaluation, because you know that if you admit a patient with natriuretic peptide level of 3,000, and after 2 days of treatment, your level is only 500, even though it's still high, this patient will have a lower cardiovascular mortality and will have a lower readmission rate at 6 months. So they're very useful after you obtain the entry BNP. They're very useful to obtain it during hospitalization to see how your patient is doing. If you actually look at the NT-pro and BNP level at discharge, it actually predicts the 1-year mortality. If it's less than 3,000, there is a significant reduction of about 50% in mortality at 1 year, because those patients who have a persistently high NT-proBNP level at discharge will have a 50% mortality at 3 years if at discharge their level was more than 3,000. And the change in the level in hospital, the drop by 30% between admission and discharge, even if it's still high, is a major predictor of better prognosis. If you admit the patient in hospital and you give them treatment and their NT-proBNP rises by over 30%, they're 6.6% more likely to die or to be hospitalized in 6 months' time when you discharge those patients. So patients whose proBNP levels fall during admission have lower cardiovascular mortality and lower readmission rate at 6 months. And discharge planning is really aided, and you can send the patients home with more reassurance, because it's very unlikely, even when you start the patient on a fantastic medication like sacubitril/valsartan, even when you do that and the patient, the echo does not improve in 4 or 5 days in hospital, it does not improve in 1 week. We know there will be remodeling, there will be improvement, but it'll take months or weeks. But the proBNP will drop, and you will know that your patient who's also feeling better, leading less diuretic, you will be reassured when you see the number on the blood tests. So you need an objective marker to easily monitor the patient's condition for improved outcomes. And you need to tackle some challenges in monitoring patients, because when we started using the natriuretic peptides with sacubitril/valsartan, we discovered very quickly that early on we could not use BNP, because as I'll show you in a minute, BNP may actually rise and the patient might be getting better. So we need to use the N-terminal portion, the NT-proBNP. The high circulating natriuretic peptides predict an unfavorable outcome in patients with heart failure. A decrease in natriuretic peptides during recovery is associated with better prognosis. There is value of natriuretic peptides testing during heart failure monitoring. It should not really target your treatment. We don't use natriuretic peptide targeted treatment because this has failed. We use more clinical parameters, but this is like a surrogate, like a test which shows us how to do things. If your natriuretic peptides remain high in red, you have the worst outcomes, mortality and rehospitalization, as you see here, of 25%. If they rise, your patients are doing badly. If they fall, this is an improved outcome. Of course, the best outcomes is if they were low and they remain. This is in a 4-month follow-up period. Sacubitril valsartan actually affects BNP levels, and this may lead to misinterpretation. Because as you won't know if this is disease progression, while actually the patient might be improving and might be getting improved prognosis. Because of the neprilysin inhibition, the BNP levels actually rise, and this, with this drug, is not a bad thing. But if it is rising because your patient is doing worse, you might not know that. You might think it's rising because of neprilysin inhibition, and you might miss opportunities to intervene. On the other hand, if you panic and you think it's rising because your patient is doing well, you might over-titrate the heart failure medication and push your patient into hypotension, moving quickly from like 50 milligrams to 200 while your patient is actually doing well. So there is actually a package insert warning against using BNP in treating patients with sacubitril valsartan, especially early. BNP is not suitable biomarker for heart failure in patients treated with Entresto because BNP is a neprilysin substrate and it actually rises even if the patient is doing better. However, NT-proBNP is not a neprilysin substrate and is actually a more suitable marker. In time, after 3 or 4 months of treatment, even the BNP becomes a suitable marker, but you're better off using the NT-proBNP. This is the package of the drug. So NT-proBNP levels are unaffected by sacubitril valsartan, and they drop, and you get a rapid and a sustained reduction, and your clinical interpretation is accurate, and the lower levels of NT-proBNP you get with the drug, the better your prognosis. So in summary, I'd like to give you my last 2 slides. Using biomarkers, using NT-proBNP specifically, will improve the diagnosis of acute heart failure, will save you at least 10% of your echocardiograms, will save you at least 40 minutes in the emergency room and a 15% in cost reductions, and I'll tell you how. You should make sure that you should have a point-of-care machine, a small machine, which gives you NT-proBNP in a few minutes in primary care, which helps accurate early heart failure diagnosis and will save 2 every 5 echocardiograms. Inside the hospital, NT-proBNP will aid your discharge planning and will avoid early readmission, will reduce your mortality. Disease monitoring outside hospital. This is an objective, easy-to-use tool. Patients can go to labs, send you results, and you can bring them in early if their NT-proBNP is rising, or you can reassure them. You can also up-titrate their medications. It is actually the suitable biomarker, is specifically suitable for patients using the gold standard now in heart failure with sacubitril valsartan. One last thing is we now have new cutoff points. So we know that with BNP, all patients who are not on sacubitril valsartan, heart failure is unlikely with BNP if it's less than 100, and it's very likely if it's more than 500. There's a gray zone between 100 and 500. NT-proBNP, and I'll show you in the next slide, there's an age. We discovered that there's an age thing. Because if you get a patient who's 80 years old with an NT-proBNP of 800, most probably your patient does not have heart failure. So I'll show you the cutoff points in this slide. We now have a triple cutoff point. So we use in patients who's the 300 rule off in all patients is 99% sensitive. But if your patient is less than 50 years of old, 450 is the rule off. 50 to 75 is 900. Older patients, 1800. So if you get a patient who is 80 years old with 900, maybe you should do an echo. You're not 100% sure. But if they are 200, you know you can send them home. So what are the obstacles? This is my last slide. What are the obstacles in Egypt for using this lab test? By the way, in my own practice, I have no obstacles. Because of the knowledge gap, I studied it, and you saw now some data. And we have a duty as the Societies of Cardiology and Heart Failure to spread the knowledge on how to use the natriuretic peptides. Availability, I actually have a small handheld drop of blood like a glucose check machine, which is cheap, which shows me the NT-proBNP in less than 10 minutes. Just like I showed you, I use my point of care echo, because I want to know if this patient who's sitting in front of me with acute dyspnea, I do a point of care echo, I do a point of care cheap lab test. There is no point in sending my patient to a large lab who's going to charge them 10 times the price of the test and give me the result up to 1 month. And this is a killer for the test. The test should be available in the hospital, in the intensive care unit, in the emergency room. It should be cheap, and it is cheap. This is a test which should cost less than about 50 Egyptian pounds, less than $5. And that is the real cost. So when your patient is asked to pay £1,000, we should do something about that. This test should not be expensive, just like the echo should not be expensive. But the echo needs expertise. The test needs a nurse. A nurse can interpret this test. NT-proBNP, if you start doing that, you're actually doing now what your patients will need next. Please learn how to use it. Please make sure you obtain, and I can help you with obtaining that and telling you how to get it cheap and how to use it. And this is what your patients really need. Thank you very much. And again, I thank you for your attendance. And I thank the sponsors. I thank our chairman, and the previous speakers, and of course, the organizers. Thank you very much. I'm happy to take any questions.
Thank you, Dr. Hani, for outstanding informations. And now we know more and more about biomarkers, how it is important for diagnosis, managing, monitoring, and how we can know information about the prognosis. And having a biomarker with clinical and echo, it is not an option to have an accurate management and optimum management. Thank you, Dr. Hani, for this outstanding information. Thank you.
You're welcome. You're welcome. Are there any questions?
We do not have a question now. Now you answer all the questions.
Thank you.
Thank you, Prof.
Thank you very much.